Androgen Insensitivity Syndrome is a genetic condition that affects how the body responds to male sex hormones called androgens. People with AIS have XY chromosomes, which are typically associated with male biological development. However, their cells are partially or completely unable to respond to testosterone and related hormones. During fetal development, testosterone normally directs the formation of male reproductive organs. In AIS, because the body cannot use these hormones properly, this process does not occur as expected. As a result, external genital development follows a more female-typical pattern, even though internal testes are present instead of ovaries. There are three main forms of AIS. In complete AIS, the body does not respond to androgens at all. Individuals are born with female external anatomy and are usually raised as girls. They do not have a uterus and do not menstruate. In partial AIS, the body responds weakly, leading to ambiguous or mixed genital development. In mild AIS, external anatomy appears male, but infertility or low sperm production may occur. AIS is often discovered during puberty, when menstruation does not begin, or when fertility problems appear. Diagnosis involves genetic testing, hormone analysis, and imaging. Treatment focuses on hormone management, monitoring of internal organs, and psychological support. Mayer-Rokitansky-Kuster-Hauser syndrome is a congenital condition that affects the development of the female reproductive system. Individuals with MRKH have XX chromosomes and normal female hormone production, but the uterus and upper portion of the vagina do not fully develop before birth. During fetal development, two structures called Mullerian ducts normally form the uterus, cervix, and upper vagina. In MRKH, these ducts fail to develop properly. As a result, the uterus may be very small or completely absent, and the vaginal canal is shortened or missing. The ovaries, however, develop normally and produce estrogen and eggs. Because hormone production is normal, puberty occurs on schedule. Breast development, body hair growth, and voice changes follow typical female patterns. The condition is usually discovered when menstruation does not begin in adolescence. Medical evaluation then reveals the absence of a functioning uterus. MRKH does not affect sexual desire or ability to experience arousal. Vaginal length can sometimes be increased through non-surgical dilation or surgical reconstruction. Fertility is affected because pregnancy cannot occur without a uterus. However, individuals with MRKH can produce eggs, making in vitro fertilization with a gestational surrogate possible. Diagnosis involves ultrasound, MRI imaging, and chromosome testing. Treatment focuses on physical development, reproductive counseling, and long-term psychological support. Kallmann syndrome is a genetic disorder that interferes with sexual development by disrupting the release of key reproductive hormones from the brain. It affects the hypothalamus, a region that controls hormone signaling for puberty and fertility. In typical development, the hypothalamus releases gonadotropin-releasing hormone, known as GnRH. This hormone signals the pituitary gland to produce luteinizing hormone and follicle-stimulating hormone. These hormones stimulate the ovaries or testes to produce estrogen or testosterone. In Kallmann syndrome, GnRH is absent or severely reduced, so this entire signaling system fails. Without proper hormone signaling, puberty does not begin normally. In males, this may result in minimal facial hair, small testes, lack of voice deepening, and low muscle development. In females, breast development may be delayed or absent, and menstruation does not start. In both sexes, fertility is impaired. A defining feature of Kallmann syndrome is reduced or absent sense of smell. This occurs because the nerve cells responsible for smell and GnRH production fail to migrate correctly. During fetal development, diagnosis involves hormone testing, smell testing, genetic screening, and brain imaging. Treatment typically includes hormone replacement therapy to induce puberty and support sexual function. Fertility can often be restored through specialized hormone treatments that stimulate egg or sperm production. Persistent Mullerian duct syndrome is a rare genetic condition that affects individuals with XY chromosomes and typical male hormone production. In this disorder, internal female reproductive structures remain present alongside male reproductive organs. During normal male fetal development, the testes produce two key substances, testosterone and anti-Mullerian hormone. Testosterone supports the formation of male external genitalia. Anti-Mullerian hormone causes the Mullerian ducts, which normally form the uterus and fallopian tubes, to disappear. In PMDS, the body fails to produce anti-Mullerian hormone or cannot respond to it properly. Because of this failure, the Mullerian ducts remain and develop into internal structures such as a uterus and fallopian tubes. At the same time, testosterone functions normally, so external genitalia appear male. Most individuals with PMDS are raised as boys and have typical male physical appearance. PMDS is often discovered accidentally during surgery for undescended testicles or hernias. Doctors may unexpectedly find uterine tissue inside the abdomen. The presence of these structures can interfere with testicular descent and sperm production. Fertility may be reduced because undescended testes are exposed to higher body temperatures, which damages sperm cells. There is also an increased risk of tumors in retained gonadal tissue. Diagnosis involves imaging, hormone testing, and genetic analysis. Treatment may include surgical removal of Mullerian structures and monitoring of reproductive health. Congenital adrenal hyperplasia is a group of inherited disorders that affect how the adrenal glands produce hormones. The adrenal glands sit above the kidneys and normally produce cortisol, aldosterone, and small amounts of sex hormones. In most cases of CAH, the body lacks an enzyme called 21-hydroxylase. This enzyme is necessary for making cortisol and aldosterone. When these hormones cannot be produced properly, the body redirects hormone production toward androgens, which are male-type sex hormones such as testosterone. Excess androgen production begins before birth. In genetic females, this can cause the external genitalia to appear ambiguous, with enlargement of the clitoris and partial fusion of the labia. Internal female organs usually develop normally. In genetic males, genital development appears typical, but early puberty may occur. Low cortisol and aldosterone levels can also cause serious medical problems. These include dehydration, low blood pressure, low blood sugar, determined salt loss, and life-threatening adrenal crises. Without treatment, severe forms can be fatal. Diagnosis is made through newborn screening, hormone testing, and genetic analysis. Treatment involves lifelong hormone replacement to correct cortisol and aldosterone deficiency and suppress excess androgen production. With consistent medical care, most individuals develop normal sexual function and fertility. Swyer syndrome is a genetic condition in which an individual has XY chromosomes but develops a female external body structure. The condition occurs because the testes fail to form properly during early fetal development. In typical male development, a gene called SRY on the Y chromosome triggers the formation of testes. These testes then produce testosterone and anti-Mullerian hormone, which guide male internal and external development. In Swyer syndrome, mutations in SRY or related genes prevent this process. As a result, functional testes never develop. Without testosterone or anti-Mullerian hormone, the body follows a default female developmental pathway. External genitalia form in a female pattern, and a small uterus and fallopian tubes may be present. However, the gonads remain underdeveloped and are replaced by non-functional tissue called streak gonads. Because the gonads do not produce sex hormones, puberty does not proceed normally. Breast development is minimal, menstruation does not begin, and bone density may be reduced. The condition is usually discovered during adolescence due to delayed puberty. Diagnosis involves chromosome analysis, hormone testing, and imaging studies. Treatment includes removal of streak gonads due to cancer risk, followed by estrogen replacement therapy. Pregnancy may be possible using donor eggs and assisted reproductive technology. Aphallia is an extremely rare congenital condition in which a genetic male is born without a penis. The condition occurs during early fetal development when the genital tubercle, the structure that normally forms the penis, fails to develop. In typical male development, the genital tubercle grows under the influence of testosterone and dihydrotestosterone. These hormones stimulate the formation of the shaft, glands, and urethra. In aphallia, this process is disrupted before these structures can form. Individuals with aphallia usually have normal testes and male chromosomes. The scrotum may be present, and testosterone production is often normal. Urine exits the body through an abnormal opening near the perineum or rectum, known as a perineal urethra. Because the penis is absent, sexual intercourse and typical urination are not possible without medical intervention. The condition is usually diagnosed at birth. Management requires a multidisciplinary medical team, including urologists, endocrinologists, and mental health specialists. Treatment options may include surgical reconstruction, urinary diversion procedures, and hormone therapy. Psychological support is critical due to the emotional and social challenges associated with the condition. Long-term outcomes vary depending on surgical success and individual adaptation. Cloacal exstrophy is a rare and severe congenital condition that affects the development of the lower abdominal wall, urinary system, digestive system, and reproductive organs. It occurs very early in fetal development when the structures that normally separate the bladder, intestines, and genital organs fail to form correctly. In typical development, the cloaca divides into separate urinary, digestive, and reproductive openings. In cloacal exstrophy, this separation does not occur. As a result, the bladder is split and exposed on the surface of the abdomen, and parts of the intestines are located outside the body. The external genitalia are also severely affected. In genetic males, the penis may be divided or underdeveloped. In genetic females, the clitoris and vaginal opening may be malformed or absent. Internal reproductive organs may also be displaced or incomplete. The condition is diagnosed at birth due to visible physical abnormalities. Immediate medical intervention is required to protect exposed organs and prevent infection. Treatment involves multiple complex surgeries over many years to reconstruct the bladder, intestines, and genital structures. Sexual function and fertility vary widely depending on surgical outcomes. Some individuals are able to achieve sexual activity and reproduction, while others experience long-term limitations. Lifelong medical monitoring and psychological support are essential for overall health and quality of life. Severe hypospadias is a congenital condition in which the urethral opening is located far from its typical position at the tip of the penis. In severe cases, the opening may be located near the base of the penis, within the scrotum, or in the perineal area. During normal fetal development, the urethral tube forms and closes along the underside of the penis. This process is guided by androgens, particularly dihydrotestosterone. In hypospadias, this closure is incomplete. The more severe the hormone disruption or developmental interruption, the further back the urethral opening remains. Severe hypospadias is often accompanied by other structural issues. These may include downward curvature of the penis, known as chordee, incomplete foreskin development, and abnormal penile length. These abnormalities can interfere with urination, erection, and ejaculation. The condition is usually diagnosed at birth based on physical examination. In severe cases, the appearance of the genitalia may be ambiguous, requiring careful evaluation to confirm chromosomal sex. Imaging and hormone testing may be used to assess internal anatomy. Treatment typically involves surgical reconstruction during early childhood. The goal is to reposition the urethral opening, straighten the penis, and improve functional outcomes. Without treatment, severe hypospadias can lead to chronic urinary problems, sexual dysfunction, and infertility. Micropenis is a medical condition in which the penis is significantly smaller than the average size for age and developmental stage. It is diagnosed when the stretched penile length is more than 2.5 standard deviations below the population mean for newborns, children, or adults. The condition results from inadequate exposure to androgens during critical stages of fetal or early postnatal development. Testosterone and dihydrotestosterone are required for normal penile growth. When production is low, hormone receptors are defective, or brain signaling is impaired. Penile development is reduced. Common causes include hypogonadotropic hypogonadism, pituitary disorders, genetic mutations, and defects in testosterone synthesis. In some cases, the cause remains unknown. Micropenis is not caused by masturbation, sexual activity, or lifestyle factors. Micropenis does not automatically prevent sexual function or fertility. If testicular function and sperm production are normal, reproduction is possible. Sensitivity and erectile capability are often intact. However, psychological distress is common due to social stigma and self-image concerns. Diagnosis involves physical measurement, hormone testing, genetic analysis, and brain imaging when necessary. Treatment may include testosterone therapy during infancy or puberty to stimulate growth. Surgical intervention is rarely recommended and is reserved for severe cases with functional impairment. Primary severe vaginismus is a condition in which the muscles surrounding the vaginal opening contract involuntarily, making vaginal penetration extremely painful or physically impossible. The contractions occur automatically and are not under conscious control. The primary muscles involved are the pelvic floor muscles, especially the pubococcygeus muscle. In individuals with vaginismus, these muscles tighten reflexively in response to attempted penetration, medical examination, or even anticipation of contact. This response is similar to a protective reflex. Primary vaginismus means the condition has been present since first attempts at penetration. It is different from secondary vaginismus, which develops later after injury, infection, or trauma. Primary severe cases often prevent tampon use, gynecological exams, and sexual intercourse. The condition is commonly associated with anxiety, fear of pain, past negative sexual experiences, strict sexual upbringing, or misinformation about sexuality. However, it can also occur without any identifiable psychological trigger. In some cases, nerve sensitivity or pelvic pain disorders contribute. Diagnosis is based on medical history, symptom description, and gentle physical examination when possible. Treatment involves pelvic floor physical therapy, graduated dilator use, cognitive behavioral therapy, and relaxation training. With consistent treatment, most individuals can achieve comfortable penetration and normal sexual function. Persistent genital arousal disorder is a neurological and sensory condition characterized by continuous, unwanted genital arousal that occurs without sexual desire or psychological stimulation. The arousal is physical and involuntary and does not resolve through normal sexual activity. The condition involves increased blood flow, nerve sensitivity, and abnormal signaling in the genital region. It is believed to be linked to dysfunction in the pudendal nerve, pelvic nerves, or spinal cord pathways that regulate sexual sensation. In some cases, vascular abnormalities or pelvic congestion contribute to symptoms. Individuals with PGAD may experience genital swelling, throbbing, tingling, lubrication, or sensitivity that persists for hours, days, or longer. These sensations are often triggered by sitting, vibration, stress, or movement. Orgasms may provide temporary relief, but usually do not resolve the condition. PGAD is frequently misdiagnosed as hypersexuality or psychological arousal, which leads to delayed treatment. In reality, most affected individuals find the symptoms distressing and disruptive. The condition can interfere with sleep, work, relationships, and mental health. Diagnosis requires exclusion of hormonal disorders, infections, and structural abnormalities through imaging and neurological testing. Treatment may include nerve-targeting medications, pelvic physical therapy, antidepressants, pain modulators, and management of underlying spinal or vascular conditions. Treatment effectiveness varies widely between individuals. Sexsomnia is a sleep disorder in which a person engages in sexual behaviors while asleep and has no conscious awareness of their actions. It is classified as a type of parasomnia, which is a group of disorders involving abnormal behaviors during sleep. The condition occurs during non-REM sleep, particularly during deep sleep stages. In these stages, parts of the brain responsible for movement may become active, while areas responsible for awareness and judgment remain inactive. This partial awakening allows complex behaviors to occur without conscious control. Individuals with sexsomnia may engage in actions such as touching, masturbation, verbal sexual expressions, or attempted intercourse. They typically have no memory of these events upon waking. Episodes may last from seconds to several minutes. Sexsomnia is often associated with other sleep disorders, including sleepwalking, sleep apnea, insomnia, and restless leg syndrome. Triggers may include sleep deprivation, alcohol use, stress, and irregular sleep schedules. Certain medications can also increase risk. Diagnosis involves sleep history analysis and overnight sleep studies called polysomnography. These studies monitor brain activity, muscle movement, and breathing patterns. Treatment focuses on improving sleep hygiene, treating underlying sleep disorders, avoiding triggers, and sometimes using medication to stabilize sleep cycles. Pathological adult phimosis is a condition in which the foreskin cannot be retracted over the head of the penis due to abnormal tightening, scarring, or inflammation. Unlike normal childhood phimosis, which resolves naturally, pathological phimosis develops as a medical problem in adolescence or adulthood. The condition is usually caused by repeated infections, poor hygiene, chronic inflammation, diabetes-related skin changes, or skin disorders such as lichen sclerosus. These factors lead to fibrosis, which is the formation of stiff scar tissue in the foreskin. When the foreskin cannot retract, cleaning beneath it becomes difficult. This allows bacteria and debris to accumulate, increasing the risk of balanitis, urinary tract infections, and unpleasant odor. In severe cases, urination may become painful or obstructed. Pathological phimosis can interfere with sexual activity by causing pain during erection and intercourse. It may also reduce sensitivity or cause tearing of the foreskin. In rare cases, untreated phimosis increases the risk of penile cancer due to chronic inflammation. Diagnosis is based on physical examination and medical history. Treatment options include topical steroid creams to reduce inflammation, manual stretching exercises, and surgical procedures such as circumcision or prepudioplasty. Early treatment prevents long-term complications and restores normal function. Compulsive sexual behavior disorder is a condition in which an individual experiences persistent, uncontrollable sexual urges and behaviors that interfere with daily functioning, relationships, and mental health. In severe cases, the behavior becomes repetitive and resistant to self-control. The disorder involves dysfunction in the brain's reward system, particularly in pathways involving dopamine. Dopamine regulates motivation, pleasure, and habit formation. In affected individuals, sexual activity produces exaggerated reward responses, reinforcing compulsive patterns similar to addiction mechanisms. Common behaviors include excessive masturbation, compulsive pornography use, repeated anonymous sexual encounters, and risky sexual practices. These behaviors continue despite negative consequences such as relationship breakdown, job loss, financial problems, or legal issues. Compulsive sexual behavior is often linked to underlying conditions such as depression, anxiety, obsessive-compulsive disorder, attention deficit disorders, and trauma-related disorders. It may also be worsened by substance abuse or impulse control deficits. Diagnosis requires clinical assessment by mental health professionals, focusing on behavioral patterns, distress levels, and functional impairment. Treatment includes cognitive behavioral therapy, impulse control training, support groups, and, in some cases, medications that regulate mood or reduce sexual drive. Long-term management focuses on relapse prevention and behavioral stability. Ovotesticular disorder of sex development is a rare condition in which an individual has both ovarian tissue and testicular tissue present in the same body. This tissue may exist as separate organs, as combined structures called ovotestes, or in different locations on each side of the body. The condition occurs during early embryonic development when genetic and hormonal signals that normally direct the formation of either ovaries or testes become disrupted. Variations in sex-determining genes, chromosome mosaicism, or hormonal pathway abnormalities can interfere with typical gonadal differentiation. Chromosomal patterns in this condition vary. Some individuals have XX chromosomes, others have XY chromosomes, and some have mixed or mosaic patterns. Because of this variation, physical development differs widely. External genitalia may appear typically male, typically female, or ambiguous. Internal reproductive structures may include parts of both male and female systems. Hormone production depends on the balance of ovarian and testicular tissue. Some individuals produce both estrogen and testosterone in varying amounts. Puberty may involve mixed secondary sex characteristics, such as breast development combined with facial hair growth. Diagnosis involves genetic testing, hormone analysis imaging, and tissue biopsy. Fertility is rare, but possible in limited cases. Treatment focuses on medical monitoring, cancer risk management, hormonal regulation, and individualized reproductive counseling.